Welcome to the Clinical Trials Methodology course webinar series. Today's webinar is on sample size. Before I introduce our presenter, I'd like to remind you to stay muted during the presentation unless you have a question or comment. You may unmute yourself to ask a question or type your question in the chat box to the right of your screen. Also, at the end of the webinar today, if you would please take a moment to evaluate the webinar, I'll provide the link at the end of the presentation in the chat box. Now I'd like to introduce our presenter today. It's Dr. Yeatts. She is an Associate Professor of Biostatistics in the Department of Public Health Sciences at the Medical University of South Carolina. She is a faculty member with the Data Coordination Unit that specializes in the design and coordination of multi-center clinical trials, and she is also a member of our CTMC core faculty. She has a strong background in biostatistics with specific training and experience in the planning, implementation, and analysis of phase 1 through 3 clinical trials. As the PI of the Statistics and Data Management Center for the phase 1 and 2 trials of deferoxamine and ICH, Dr. Yeatts is responsible for the design of the trial and the implementation of the statistical and data and project management work scope. Dr. Yeatts is the PI of the National Data Management Center for Diffuse 3. In addition, Dr. Yeatts was the primary unblinded statistician for the large phase 3 trials IMS-3 and PROTECT-3. As a co-investigator on these grants, she was responsible for the statistical monitoring of data and the implementation of interim and final efficacy and safety analyses. Dr. Yeatts serves on data and safety monitoring boards and as a grant reviewer for several funding agencies, and her primary research interests include the development and implementation of efficient early phase trial designs and novel trial outcomes. So I'd like to send a special thank you to Dr. Yeatts for her time and presentation today. And you can get started.
Thanks, Joy. Can you hear me okay?
Yes.
Okay, great. Joy, if you'll remind me next time, we can probably shorten that intro.
Okay. I didn't want to miss anything.
Yeah. We'll work on it for next time. Thank you for that introduction. I am going to spend some time talking to you about statistics and sample size today, but there's not going to be any equations in this presentation. I realize that it's lunchtime and statistics is not often everyone's favorite topic, so we're going to keep it sort of high level. If you have any questions, please feel free to stop me. And I am going to start. Oh, maybe there we go. I'm going to start by showing you a video, which from my perspective is the real reason to have a lecture like this, because I want you all to be prepared and to have realistic expectations when you go into these initial collaborations with your statisticians. Joy, if you can't hear this video, please give me a holler and I will try to turn up the volume. Yeah, you can't hear it. Hang on.
I can't hear it, no.
Yeah, hang on. Turn it up. All right, let's try again. Oh, maybe not better.
No, I can't hear it.
Okay. I don't think
Oh,
I can.
it's low. I can hear a little bit, but it's really low.
I'm not sure why. Okay, well, the link is, if you all can't hear it, I'm not going to make you suffer through it. So the general gist is that there's a scientist talking to a statistician, and basically he comes to the statistical collaborator the day before the grant is due, and the conversation is very much one-sided. He just wants to know, he wants confirmation that he can use 3 patients to do his study. And there's lots of questions that are being asked by the statistician, and it keeps coming back to he just wants to know if he can use 3 patients. And at the end of this video, what happens is that he offers to cover the statistician for a 1% effort on the grant if it's funded. And she tells him to go away. So that would obviously never happen with any of the statisticians who were working on the clinical trials methodology course. None of us would ever tell you to go away. But this is the sort of conversation that we have all had at some point in our career. And so hopefully the purpose of this lecture is to go through some of the topics that will come up during that first conversation, and sort of set the stage for the expectations for that collaboration and how the sample size comes about. I think many people assume that it's a one-time, 1-hour meeting and you're going to leave with an answer, and that is very rarely, if ever, the case. Okay, so, all right, some disclosures. I do receive or have received some consultant fees for my role on PRISMS and Intrepid, but I'm not going to talk about any commercial products in this talk. So I'll start with a disclaimer, which is that this talk is really geared towards the design of a superiority study. And what I mean by that is any 2-arm randomized trial where you want to show that one treatment is better than the other. That primary outcome that you're trying to show superiority on may not be clinical outcome at this stage of the game. It might be a biomarker or some sort of not a subclinical finding, but a softer outcome, quality of life or something like that. But the intention is to show that one treatment is better than the other, and you hope to do that with the p-value from a hypothesis test. Now, why do I need to tell you that up front? Many of the trainees start this process thinking that this is the sort of design that they're working on. And then over the course of discussion with their small group leaders wind up going a very different direction. And there's lots of different trial designs. In some cases, what you're really shooting for is not necessarily superiority. You might be interested in showing futility or non-inferiority. You might wind up with a design where the end game is not a hypothesis test, where that's not the best way to answer your question. You might be looking for an estimate of precision associated with the outcome that you've chosen, or you might be trying to find a region of doses where the intervention is actually doing something. And in those cases, for some of these other trial designs, some of the factors that we're going to talk about here are going to be more or less or not relevant at all. Okay, so I can't tell you everything you need to know about design and sample size in this 1 hour. So I'm going to focus on superiority and just want to make you aware that there are other approaches, and you should inquire with your collaborators about those if you start thinking that maybe a p-value and a hypothesis test is not really going to answer the question that you're asking. So why do we worry about power and sample size? On the surface, we say that we worry about power and sample size because we want to provide assurance that we have a reasonable probability of answering our question, right? We don't want to collect data on 20 subjects and know up front that that is not enough and we're going to have a huge confidence interval and we're not really going to be able to say anything about the question that we're asking. In practice, we do this because it allows us to figure out exactly the sample size that we need so that we're not using too few and we're not using too many. And as long as we do that, then the funding agencies or institutes can efficiently allocate their resources, right? Because money that goes to fund one grant is money that is not available to fund another. So we don't want to overspend. But there's also an ethical justification, which is that if the study is too large, then we are needlessly exposing additional subjects to intervention that didn't really need to be exposed to that additional risk. On the flip side, if the study is too small, then again, it's sort of needlessly exposing patients because we're not going to get to be able to conclude what we're trying to conclude with any certainty. That's sort of on the surface why we worry about power and sample size from the beginning. But really, when it comes down to what you all are going to be doing on a day-to-day basis, the reason we think about power and sample size prospectively is to avoid being in a scenario where we have to make a conclusion that we're not entirely comfortable with because we didn't expend enough resources in terms of patients when we were designing the study. So I'm going to use as an example this trial that was published in the New England Journal of Medicine a couple of years ago in 2015. This is the Therapeutic Hypothermia After Out-of-Hospital Cardiac Arrest in Children study. So these children had cardiac arrest that required chest compressions for at least 2 minutes and remained dependent on mechanical ventilation after return of circulation. And the treatment of interest was targeted temperature management. So these kids were randomized to therapeutic hypothermia versus therapeutic normothermia for 120 hours. And the primary outcome that was specified for the trial was survival with a good neurobehavioral outcome at 12 months. And the trial was powered to detect an absolute effect size of 15 to 20%. Okay, that's what's written in the manuscript. So the sample size for the study is 276 children. Now, not knowing a whole lot about this disease area, automatically I can say that a 15 to 20% absolute improvement in the proportion of surviving subjects with a good outcome seems like a big effect size, right? And what we'll talk about later is that we really want to design our studies so that we are powered to detect the smallest effect size that we would be interested in. And so just by reading the sample size justification, I'm already a little bit, not necessarily concerned, but I'm wondering, well, wouldn't something smaller still have been meaningful? And in fact, when they reported the results, 20% of subjects in the hypothermia arm versus 12% of subjects in the normothermia arm achieved this primary outcome. So that's an 8% absolute improvement. Okay, but the p-value resulting from their statistical test was 0.14. Okay, not a statistically significant finding. So the authors correctly conclude that in these children, therapeutic hypothermia did not confer a significant benefit in survival with a good functional outcome at 1 year. But again, that's an 8% absolute improvement. We can sort of quibble about whether or not 8% is sort of that minimum important difference that we would want to detect. If it were 1 or 2%, that would be easier, but in the 8% range, it's a little more of a question, right? And in fact, the authors address this in the discussion. So one important potential limitation that they report is that they cannot rule out a potentially important clinical benefit. Okay, and they say a larger trial might have detected a smaller intervention effect. So really, when we design studies, we often come about the power and sample size question with this in mind. What we really want to avoid is a scenario where we see an estimate that looks like it's clinically meaningful, but that we were not powered to detect. Okay. So how do we go about doing that? There's lots of factors that are important in determining the sample size, and we're going to talk about each of these in some level of detail. The first two are concepts that I'm sure that you've heard of, and these are really things that you can have in the back of your mind already, even before the first meeting with your statistical collaborator. So you can think about what the level of significance should be for your study. And you can think about what power level do you want to target. And again, we'll talk about what each of these means in case anyone is not familiar. We're going to talk about the minimum scientifically important difference. I referred to it earlier as the minimum clinically important difference. It's the same concept. What effect size are you targeting with your study? And then two things that we think about from a statistical standpoint, we think about a lot, but is not necessarily at the forefront of our clinical collaborators' minds, are these issues of variability in the response and how that impacts the sample size, and how the experimental design that we chose can impact the sample size. So we're going to talk about each of these things. But before we do that, we have to start at the beginning. Many of you have already met several times with your small groups, and so you should be really good right now at stating your research question in terms that are perfectly interpretable to your clinical colleagues, right? Even if someone does research in a dissimilar area, you can probably state the question in a way that makes sense to another clinician. Well, when you meet with your statistical collaborator, what they're going to help you do is to translate that research question in words to statistical hypotheses. And so what we have to try to do is to state the research question specifically in a way that reflects something that's testable. And what that often means is that we need more information than you would typically use just in discussing with colleagues. So we want to know, when you're thinking about that hypothesis and writing it out, what is the population that you're studying and what are you comparing it to? Okay, so when it's written down, you want to make it obvious. Are you comparing to historical data? Are you comparing to a concurrent control? Are you comparing each patient to themselves? At a pre and a post time point, what is it that you're comparing? The next thing that should be clear is, what's the response variable that you're looking at? Okay, so don't just say that the intervention is going to have a reasonable safety profile. Tell me what safety means in this patient population. What specific outcomes are you looking at? Or don't say that the intervention is going to improve outcome. Even neuropsych outcomes, that can mean so many things. So be specific as far as stating the response variable. And at what time point are you interested? The response variable in some cases is measured multiple times during the course of the patient's follow-up. Are you looking at that whole time course and making a comparison? Or are you looking only at the 30-day outcome or the 90-day outcome and so forth? So often we need that additional information to help us think about how this is going to be approached from a statistical perspective. Then we take that information and we work with our clinical collaborators to reframe that statement into what is called a statistical hypothesis. Okay, there are two hypotheses in the typical statistical framework. There is an alternative hypothesis and a null hypothesis, and these reflect two possible states of nature. What I mean by that is that only one can be true, and there is no third option. Okay, so the alternative hypothesis is the easier one to state because it's what you want to show. If you think about the abstract of the manuscript that you hope to write after your study is finished, that concluding statement, right, that the intervention improves outcome on this patient population at 90 days, that's what you want to show. That's the alternative hypothesis. And the null hypothesis then is just the opposite of that. What is true if the alternative is not true? In the definitions you see on the screen, what I've said is that the null hypothesis is the statement we hope to contradict with data. And this is an important concept because at its most basic level, statistics is essentially a framework for proof by contradiction, right? So if you remember back to when you learned the scientific method in middle school, perhaps, you learned about proof by contradiction. This is essentially what we're doing here. As statisticians, we start out conceptualizing nature as belonging to either one state or the other. Either the null hypothesis is true or the alternative hypothesis is true. As a statistician, my preference is for the null hypothesis. I have to believe that there is nothing going on unless the data convince me otherwise. So we start with this belief that the intervention does nothing, We collect data from the real world, and only if the data clearly contradict that null hypothesis do we conclude the alternative. Okay? The only other possibility is that random noise or measurement error or chance are just as likely to have yielded the data that we saw, in which case we maintain our preference for the null hypothesis. There's no reason to believe anything more complicated is happening. Okay, so if there are two true states of the null hypothesis is either true or it's false, and I'm going to take a little segue and say that there are only two decisions that we can make as a result of a statistical test. We can either reject the null hypothesis and conclude that the alternative is true, or we can fail to reject it. So we don't accept it. You will, I don't want to say never, but you will almost never hear me say, we accept the null hypothesis. That's just not how our statistical framework is set up. So if there are these two possibilities for the truth of the null hypothesis and two decisions that we can make, then what we wind up with is this 2x2 table that you see on your slide. And that 2x2 table reflects the four possible scenarios that we could wind up in when our test is concluded. Okay? Those four scenarios describe two errors and two correct decisions. Now, we never know, we're never certain which of these boxes we're going to wind up in, right? But using statistics, we can limit the likelihood that we make the errors. And that's what we need to think about, because it impacts how we think about the sample size we need for our study. So the first thing we're going to talk about is the type 1 error. Okay, so if the null hypothesis is true, but you reject the null, that means the intervention doesn't do anything, but you conclude that it's efficacious. That's a type 1 error. And we don't want to be in that situation, right? In the case of a superiority study, what that means is we're declaring an ineffective intervention to be effective. And that means there is additional risk associated with future patients that's unnecessary because the intervention they're taking is not working. So we want to limit the likelihood that we're going to make that error. And we do that by pre-specifying the level of significance at which we're going to test our null hypothesis. And we pre-specify that to be alpha, okay? And that's all I'm going to say about that. We'll talk about it a little more in just a minute. If the null hypothesis is true, the intervention doesn't work, and we fail to reject the null hypothesis, that's a good decision. It's not a very exciting decision, but it's a good decision. If the null hypothesis is false, okay, and we fail to reject it, that means the intervention works, but we're not able to conclude that it works. That's what we refer to as a type 2 error, okay, and it's related to the power. Right? If you think about that, these columns represent, each column represents the only two possible scenarios that could happen when the null hypothesis is false, then if we're not making a type 2 error, then we must be in the scenario where we're making a correct decision, right? So we limit the type 2 error probability by specifying beta, or conversely, by specifying a target power, because that's just the converse. So if the null hypothesis is false, the intervention works, and we're able to conclude that it works, that's a good decision. And we want to have a high likelihood of being in that box, right? And so we do that by thinking about the power that we want our test to have under certain circumstances, and we think about that from the beginning. So again, we have to think about what each of these pieces mean in order to think about how we should pre-specify them and what we should target. So the level of significance is interpreted by saying even when the null hypothesis is true, so even if the intervention does nothing, you're going to conclude that it works alpha times 100% of the time, okay? So this is pre-specified during the design stage, and it should be chosen to reflect your willingness to accept a false positive. But everybody knows that it has to be 5%, right? Only it doesn't have to be 5%. It's often 5%. It is very often assumed that it has to be 5%, but in reality, it should be chosen to reflect the consequences of making this decision. So for instance, if you are evaluating a surgical intervention where there is a high risk associated with the intervention, then 5% false positive rate might not actually be acceptable to the community, right? There's all this extra risk. You're going to put the person under probably general anesthesia. There's risk associated with that. There's risk associated with the surgery itself. Maybe you need a false positive rate of 1% in order to conclude that the intervention works, in order to make the community believe that it works, okay? If, on the other hand, you're studying an exercise regimen, right, and you're trying to show that it impacts some outcome, the consequence of making a mistake, a false positive error, in that case is potentially less concerning, right? Even if the intervention doesn't actually impact the outcome that you've specified, it's hard to imagine a scenario where exercise is bad, right? So in that case, maybe a 10% false positive rate would be acceptable. So really, there is some level of flexibility for you to think through what that level of significance ought to be. And it likely depends on the type of intervention that you're studying, and it may depend as well on the phase of study that you're in. Okay, so why does this impact the sample size? What I'm showing you here is a standard normal curve, and the level of significance reflects the shaded region that you see here. So this gray shaded region covers a probability of 0.1. So under the null hypothesis, you can see this curve is centered at 0, meaning that our treatments are the same, okay? The shaded region would be our rejection region. Anything in this region would lead us to conclude that the alternative hypothesis is true, okay? As we decrease the level of significance, that shaded region is going to get smaller, okay? So larger and larger differences are going to be required in order for us to conclude the alternative. And again, that's reflecting our willingness to accept a false positive. The less willing we are, the bigger the difference, the more sure we need to be that it's not really reflective of what we would expect under the null. Okay, and again, you can see here I've just overlaid those 3 level of significance values, so you can see how the shaded region changes. We're going to see how this level of significance impacts the power by extending this shaded region to the alternative hypothesis. So if the curve that you see now is what we would expect under the null hypothesis, what does it mean when we think about the alternative? So we think about the alternative hypothesis and making that error, again, by specifying a target power. The power is the probability that a statistical test is going to reject the null when, in fact, the intervention works. And the interpretation, it's important to note, is specific to a given value under the alternative hypothesis. So you can't say, globally, we have 80% power. You have to say under certain conditions and tell people what those conditions are. And that's related to the sample size. So again, let's see how the level of significance impacts the power. Here we have 2 curves. On the left, again, is the curve that reflects what we would expect under the null hypothesis. On the right is what we would expect under the alternative, okay? And you can see, again, we talked about the level of significance. So the shaded region here under the curve on the left reflects a one-sided 0.10 level of significance. But if we extend that shaded region to cover what we would expect under the alternative, that shaded region under the alternative can be thought of as the power. And again, when we reduce the level of significance, we reduce the rejection region under the null hypothesis, you can see that the shaded region under the alternative decreases as well. Okay, so that is impacting our power. So it's something we need to think about up front. Now, the graph that I just showed you was for a specific value of the alternative hypothesis. Okay, what we want to do when we're designing a study is to think about what is the minimum scientifically important difference that we want to detect. And in sort of general terms, that's the smallest difference which would result in a change in practice. Okay, sort of the rule of thumb on this is the larger the difference, the smaller the sample size. Different disease areas may have in the literature an understanding of what this is for certain types of outcomes. But again, it's not necessarily a given. It may be something that you and your collaborating experts have to really put some thought into to decide what is the smallest difference that would change practice. How does this impact the sample size? Again, I gave you this rule of thumb. The larger the difference, the smaller the sample size. The curve I'm showing you here, again, represents the null hypothesis, and you can see the rejection region. What I'm showing you now, the curve on the right, is what we would expect under the alternative hypothesis for a 1-unit difference, okay? And so you can see that there's a lot of overlap between those curves. So for many possible outcomes as a result of the statistical test, it would be hard to say from which distribution they came, right? But as these two curves get farther apart, so now my curve is centered at a 2-unit difference. Now it's centered at a 3-unit difference. You can see that those curves become more distinct, and it's going to be easier to tell them apart. And again, from a power standpoint, you can see very clearly how that shaded region under the alternative grows as the difference between the null and the alternative gets larger. Okay. Now, we also have to think about the variability in our outcome. And what we mean by that is whether the outcome is continuous or categorical. If it's continuous, what we mean is just an estimate of the standard deviation and the variance. If it's dichotomous, then what we mean by variability is really an estimate of the control proportion. What proportion of subjects on the control arm do we expect to have a good outcome? And why does that matter? Again, this rule of thumb, the larger the difference, the smaller the sample size, ignores the contribution of variability. And so what I'm showing you here is essentially a repeat of the previous slide, where you can see what we're looking at is a difference of about 3 units between the null and the alternative. And with the variability that's present in this particular curve, you can see that they're relatively distinct, and it would probably be easy in the tails to tell which distribution your data support, right? But if the variation increases, these are centered at exactly the same place, but with the variation increasing, those curves become less distinct. And again, it becomes more difficult then to tell them apart, to tell with a particular result from which curve it's more likely. Okay, so what does this mean in practice? Excuse me, it's fine to think about it sort of in theory, but what does it mean in practice? Let's look at an example from a continuous outcome. So I'm describing a phase 2 clinical trial in subjects with acute ICH. And I'm thinking about my intervention as being intended to impact health-related quality of life. So I'm going to assess the neuroqual, and I'm assuming that my minimum clinically important difference is 1/2 of a unit on the neuroqual. So the neuroqual is a continuous outcome. I'm going to analyze it with a t-test, and I want to see a difference of 1/2 a unit between the two interventions. So what we have here, and it's perhaps a little bit hard to see. So the orange curve here is a standard deviation. Sorry, this is the red curve. It represented by a standard deviation of 0.5. So that means a standardized effect size of 1. And you can see that we can achieve 80% power with very few subjects, fewer than 50 subjects, it looks like, right? The blue curve is what we would expect if the standard deviation of the neuroqual is 1. So that's a standardized effect size of 0.5, which is still a moderate effect size, but now we need a total sample size of a little more than 100, maybe 130 in order to achieve 80% power, right? Here's our 80% power line, and we follow it down to the sample size. if the standard deviation is 1.5, as you see here in the orange line, that's the standardized effect size of 0.3. That's actually pretty small, and we can follow this 80% power all the way over here and see that we need almost 300 subjects. Okay, so we have to assume something about the standard deviation in order to come up with the sample size, but you can see here that if our assumption is wrong, it really does have the potential to impact the sample size that we would have come up with, or conversely, the power that we would have for any given sample size. What if we're talking about a binary outcome instead? So again, I'm talking about a phase 2 clinical trial in subjects with acute ICH, but now I'm thinking that my intervention is supposed to impact functional independence. So a modified Rankin scale score of 0 to 2 in this population is likely what I would pick for a phase 3 trial. So maybe I'm looking for proof of concept. I want to see if there's enough of a signal in my study to move forward. And again, in this patient population, in many instances, the trials are designed to detect a minimum clinically important difference of a 10% absolute improvement. So how many subjects am I going to need? Well, that depends on what the control proportion is expected to be. So here, the blue line, the blue curve, is assuming a control proportion of 10%. The orange line is 20%. The green line is 30%, and the red line is 40%. And so you can see that as that control proportion increases, the sample size that is required to achieve 80% outcome also increases. And again, by quite a bit. You know, this is, here is 300 patients. So you need maybe 400 patients if you're willing to assume a 10% good outcome rate in the control arm. But if it's really 40%, then you should have been up here at about 800 patients. So again, if we're wrong in those assumptions, it really does have the potential to make quite a large impact. So I'm just going to mention very briefly that in this scenario here, where we're talking about impacting functional independence, that trying to design a study that looks like a phase 3 study or a on a similar outcome that you would use in the phase 3, and winding up with a study that is underpowered to detect what would be the clinically important difference in that phase 3 is likely to get some pushback, right? So what we don't want is to propose a phase 2 that really looks like an underpowered phase 3. So if you're looking at a clinical outcome and you're looking for that proof of concept, one way that you can reframe how you're thinking about it is to consider a futility design rather than a superiority design. And I'm not going to go into the details of this because my disclaimer said I was focusing on superiority. But it's really just flipping the way that you think about it. So rather than saying, if I see a big enough effect, I'm going to move forward, when you know that it's unlikely that you're going to see that big of an effect in a small study, what if you try to show that if the effect is less than some threshold, then you know you're not interested anymore? And so what I'm showing you here is the resulting sample size savings. So again, the curves, and I'm sorry that the color has changed, but the curves go across 0.1, 0.2, 0.3, 0.4, and you can see here that under all of those scenarios, you can achieve 80% power with fewer than 500 subjects for this phase 2 futility approach, whereas a properly powered study to detect a 10% difference can take you all the way up to 800 subjects. Okay, so again, there are some other ways that you can think about framing your hypothesis that might allow you some sample size savings. And if you're in this scenario, you should feel totally comfortable talking to your statistical collaborator about what those options might be. So before you ask about sample size, you now know you need to be prepared to talk about the level of significance alpha, what kind of power you want to target, what variability there is in your response. And that could come from the relevant literature, but it would be even better to have a range of plausible values so that you can really do a sensitivity to see if I'm wrong, how much is it going to impact my sample size? You should be prepared to talk about the minimum scientifically important difference. And if that sample size proves to make the trial not feasible, then there may be ways that you can compromise by sort of fiddling with some of these other tuning parameters. And be prepared to talk about the experimental design. Again, a superiority study with a p-value outcome may not be the only way to go about answering your question. And even if it is, there may be some other considerations that you can use to keep the sample size reasonable. So do you really need a concurrent control arm? Maybe you don't. Maybe there was a recent study done at a similar set of sites using a very similar set of entry criteria, and you can use the data from that study to serve as a control. Okay. Can subjects serve as their own control? That may be a possibility as well. Can you answer multiple questions in the same design? So if you're talking about deciding between two interventions, can you do one study that looks at two interventions and a control, and that way they can share the same control group? Okay. Maybe a hypothesis test actually isn't the best way to achieve your goal. Maybe what you're really trying to do is to find a dose, and there's a whole slew of designs that are intended for that purpose. Or maybe you're interested in just selecting among a set of interventions, and again, there are other opportunities for selection. And be aware that the sample size calculation is going to depend on how the data are going to be analyzed. So again, why it's really important to specify what the outcome is, exactly what the comparison is, and at what time points, because that information is going to help to establish how the data should be analyzed. Once you have that number, you're going to have to justify it. All right, so you have to be very clear when you're writing your grant application. How many subjects are you asking for? And be honest, is that adequate for testing the hypothesis? If it's not, again, you should be upfront. Do you need more? Why aren't you asking for more? If you can answer questions with fewer, why are you asking for what you're asking for? Sometimes these things can still be justified, but you have to be honest about it. And how was the sample size determined? Sometimes it's determined based on feasibility or based on budget, and we're doing the best that we can. You still need to be able to justify it. Okay, a couple of sort of tips for keeping it small. Oftentimes studying a continuous rather than a binary outcome can be helpful. So you might study change in tumor size instead of recurrence. You might also study a surrogate outcome where the effect is large. So maybe cholesterol reduction rather than mortality, things like that. So the way, as a statistician, the way that I would prefer for this interaction to happen is for a clinical collaborator to come to me with the difference to be detected, the variability, the target power. We meet for a little while, talk about the specifics, and then I calculate a sample size. Oftentimes, either that's not possible because of feasibility reasons, or the collaborator comes to me and says, I know I can only afford 100 subjects, right? In that case, it's a little backwards, but we still go through this process. So the collaborator specifies the sample size, specifies the power, specifies the variability, and then we calculate what that detectable difference is. In either case, either the sample size or the detectable difference, actually probably both, need to be justified when writing it up. There is a ton of sample size software that's available. So there's freeware on the web. Your statistical collaborators will have purchased software likely available to them. Many folks at our place use either Inquiry or Pass. I also use East. Some folks use SAS. So again, statistical collaborators are going to have lots of options available to them. There's a quote associated with the software, the freeware on the Iowa website. And you know what? I should have checked those links again this year and I didn't. I'm sorry, but I will, and I'll update them if necessary. But one of the folks on the Iowa website related to their freeware wrote that they receive quite a few questions that start with something like this. I'm not much of a stats person, but I tried this. Am I doing it right? And the author said, please compare this with, I don't know much about heart surgery, but my wife is suffering from this and I plan to operate. Can you advise me? As I said, there's lots of software available, but there's a lot of nuances to how the different software perform calculations, the assumptions that are being made that underlie those calculations, and so forth. And so it really is beneficial. And I promise I'm not just saying this because my work every day relies on collaboration, although it does. It really is beneficial for you to find a statistical collaborator and to develop that relationship so that they can help you to avoid these sort of pitfalls as you think about the sample size calculations. A lot of folks say, well, I don't want to contact the statistician now because I don't have any money, but I don't have any funding for this particular project. But many of the statisticians who do what I do, what Chris Coffey does, what the other statistical folks in the clinical trials course do, this is the world that we work in, right? So we understand that we are going to put money into developing grants up front. We are going to put time, into developing grants up front, and some of those grants are not going to get funded. And that's sort of a hazard of what we do, but we understand that that's how it works. And so you really shouldn't let that be a reason not to reach out to someone early. We would much rather be involved from the beginning than have someone come to us and hand us a design, or worse, hand us the data from a design and saying, can you help, can you fix? Okay, so just keep that in mind. The last thing I'm just going to mention that we don't often think about as a part of a sample size calculation, but it is important to talk about, is the logistics of actually implementing the trial. So you're going to, at some point, want to talk about what the anticipated recruitment rate might be. Treatment crossovers and non-adherence are going to require additional inflations to the sample size. Loss to follow-up and consent withdrawal would require inflations. Interim analysis would require inflations, and so forth. So again, I hope I'm sort of setting the expectation that this is not likely to be a one-time, 1 hour conversation, that this may happen over the course of several meetings where there's some back and forth about all of the specifics associated with your particular scenario. And I'll end just with some famous last words. R.A. Fisher, who's a very famous statistician, once said that to call in the statistician after the experiment is done may be no more than asking him to perform a post-mortem exam. He may be able to say what the experiment died of. Okay. Does anyone have questions? I'm happy to take questions if there are any, or comments.
I'll unmute all of you, so you can you can ask a question, or if you don't want to talk, you can type in the chat box as well.
Okay, there's a comment from Katie. When writing a grant, is it okay to put in the website you use to calculate the power? Yes, absolutely. Even if you're not using a website, if you're using a software package, it's often helpful. As I mentioned, some of the nuances associated with the different software programs can give you slightly different answers. So I don't always double check a sample size calculation when I'm reviewing a grant. Sometimes you can just sort of look at it and get a sense as to whether it's in the ballpark. But if it's not in the ballpark, it helps to let me know where I can go to find something that's similar. And you should put in all of those assumptions. Don't just say, we have 85% power. Tell me under what conditions. If the literature is not clear about the MCID, is it safer to plan a proof of concept design? So I think it's the case that the literature is often not clear about the MCID. or that what your group of collaborators comes up with as the MCID is physically unfeasible, right? Sometimes we talk to investigators who say, well, if I could even improve functional independence in an additional 2% of patients, that would be worthwhile. But we can't do a stroke study that big. So I think it's often the case. I would say that whether you go for proof of concept versus a sort of fully powered phase confirmatory study depends really on where you are in evaluating your particular intervention, right? And in the case of proof of concept, it's sometimes hard, and this may be institute specific, but I think it used to be the case where you could design a phase 2 study and be relatively upfront about the fact that it was an underpowered phase 3. Say, I'm designing a phase 2 study to detect a 25% improvement in this clinical outcome, and use that estimate of the treatment effect to justify a phase 3. At least at NINDS, there seems to be a push away from that. We want to have go, no-go criteria that are clearly supported by a statistical basis. And so it's important to think about what you're actually able to demonstrate in a sort of proof of concept design, and try to avoid a proof of concept that's really an underpowered phase 3. I don't know if that answers your question. Other questions?
Last call for questions or comments. Okay, well, thank you very much, Dr. Yeatts. I appreciate your presentation today. And if anyone else has a comment or question later on, you can feel free to email me and I can forward that on. If you would please evaluate the webinar, the link is in the chat box. We would really appreciate it. Okay, well, thank you everyone. We will see you on our next webinar next week. Thanks.
Thanks. Bye-bye.